Now you okay.
Okay, wonderful. Hello, everybody, and welcome to the noon meeting organized by the Health Economics Unit. I'm Edina Sinanovic, and it is my pleasure to introduce to you today's presenter, Dr. Gitesh Solanki, who will be giving a talk on assessing the case for applying personal responsibility for COVID-19 vaccination in the South African insured population. And he's going to be talking on a particular aspect of that study, which is how to measure the impact of vaccination on hospitalization. His work is done obviously by him and his colleagues Francesca Little and Sue Cleary. So over to you, Gitesh, and after his presentation, there will be some time for questions and discussion.
Thanks, Lucy. So I'm presenting, but it's on behalf of Sue and Francesca, who I believe is online. So it's quite a mouthful, the title. I mean, it's to translate it into English. I mean, essentially what I'm trying to do, or what the study is trying to do, is to assess the case for making, during the COVID epidemic, the people who belong to medical schemes, the question is, should they have been made to pay for their hospitalization for COVID if they didn't vaccinate? And essentially, that's the question. Right? What I'm presenting, so there's 4 parts to this particular question. What I'm presenting here today is the first part of it. And the first part is, and as I go through the framework, you'll see what the 4 parts are. But the first part is to say, did COVID make a difference in terms of hospitalization risk, in terms of utilization, in terms of expenditure? So that's essentially kind of in English what we're trying to do. So my presentation is kind of standard research. I'll cover the background, do the aims and objectives, methods, results, discussions, and conclusions. And in a half an hour, one can't cover in detail, so I've got a lot of it to skim, especially in terms of the methods. But if there's any questions, please feel free to ask. And Francesca's online, so she's really the statistician, and hopefully she'll be able to help out. So the question is, the term personal responsibility, and I mean, everything is around this PR, personal responsibility. It's essentially shorthand for saying, when do you define benefits or health policies based around people's behaviors? If people behave badly, can you either withhold them or make them pay for it, or and somehow restrict access to health? So this whole thing of personal responsibility is around people's behavior and how it impacts on health. So the question is, why should we be considering personal responsibility in the first instance, right? So people make choices about how to live their lives. The choices they make impacts on their health risks in terms of their need for treatment and the demands they make on the healthcare system. Unhealthy choices or lifestyles are now a key driver of the increasing burden of disease globally. So if one looks at burden of disease globally, it's increasing, and underlying that that increase in the global burden of disease is unhealthy lifestyles. I mean, what people eat, what they drink, whether they exercise, don't exercise, etc., etc. Now, to the extent that there's an implication for distributive justice, right? So we all make demands on the healthcare system, and the question is, if you live, you make poor choices in terms of your health, you make higher demands on the healthcare system, and is that then fair for the people who are making healthier choices and making less demands on the healthcare system? So there's a whole issue of distributive justice. We all live in society, we all contribute, and the question is your bad choices now impacting, and how does it affect others? And then if one pairs that then with the issue of limited resources, especially in low middle income countries. So we're sitting with a situation in South Africa is very real right now, that we've got huge budget cuts. We're cutting healthcare services, and the question is, who's going to get services and who not? What do we cut and what don't we cut? And in this mix, should we be considering personal responsibility as one of the criterion for providing access? And that's kind of the broader context of it. Right? So let's look at South Africa in particular. So unhealthy behavior is a major driver of the burden of disease in South Africa. I mean, one looks at, we've got a quadruple burden of disease, but unhealthy behaviors constitutes a large portion of the burden of disease in South Africa. We're committed to universal healthcare, but given the resources that we have, we can't provide quality care for all needs. So the question is going to come down to what and whose needs should we prioritize and what benefits should we commit to. And currently, we operate on an implicit budget system. So basically, we put aside money for healthcare and we say, here's the budget, and you try and spend it as best you can. And it's not quite explicit in terms of trying to direct that money in the best way that you can or get the most out of it. So essentially, what we got is lacks transparency on the one hand. And secondly, if we don't prioritize explicitly and say, these are the things we want to spend and have a clear reason of why we want to spend the money on what we want to spend, then we're spending a lot of that money inefficiently and we're wasting a lot of the money as well. So there's an imperative then to say we should move from an implicit to an explicit budgeting system, one. And then the second question then comes, well, if you go explicit budgeting, it means you're prioritizing on set criteria. And again, the question then comes, in this explicit budgeting process, should personal responsibility be one of the criteria that one incorporates as part of the explicit budgeting process? No? So how did COVID vaccine come into the mix? So the issue of personal choice is a complicated one. I don't know if anybody has been watching the debates that are going on in the UK right now. So they've introduced what New Zealand tried to do, that they're going to now ban smoking people from a certain age from buying cigarettes. And I mean, it's generated a whole host of debates. I mean, and a lot of it is very real, and it's almost replicating the debates that we had during COVID. So COVID was a time when application of personal responsibility is complex. I mean, there's lots of different things. You know, when can you hold somebody responsible and deny them healthcare or charge them for their poor health behavior? I mean, so there's lots of different positions around it and lots of issues. And we've struggled. I mean, if you look at this debate that's going on in smoking, I mean, it's incredible how the different people are positioning themselves, and obviously the tobacco industry and other vested interest groups jumping into this debate. So it's a very complex thing, and people haven't, in my view, systematically dealt with it. So when COVID came through, the epidemic, the responses to COVID highlighted all the divides, and it highlighted all the weaknesses of our healthcare system, the divides within our society, the ideological divides. So remember, at the time when COVID came, we had on the one hand the Trumpians, the DeSantis in the Florida claiming that, listen, everybody should be free, there should be no mandates, shouldn't wear a mask, you should be free to do whatever you want. On the other hand, we had the Chinese model where they just locked down everything and kept people indoors. And in between, there was the Singapore model. So the Singapore model basically started off by saying right at the beginning, in Singapore, they've got a national health service or insurance which covers everybody for their healthcare needs. And at the beginning of COVID, they said, no, we'll cover all COVID-related costs at full in hospital and wherever you go. When the vaccine came out later on, they said, no, but if you don't vaccinate, then we won't cover you for your hospital care. So essentially, the argument was that you're unfairly burdening the system by choosing not to vaccinate. I found that at the time when it came out quite fascinating, and we wrote a paper or a piece in the Daily Maverick, which generated a lot of interest, and that essentially stimulated this debate of saying, why don't we use this COVID-19 and the responses to it around personal responsibility to do a broader kind of study, a proper scientific study around assessing why. So this is essentially a pilot of looking at the broader issues of how does one go about assessing when you can use personal responsibility or behavior to determine healthcare. So the other part was, well, I had some data. I mean, I work for a actuarial firm on the side. So I had access to this medical scheme data, and they had all the COVID vaccination data. And it gave me the opportunity then to look at, in a medical scheme population, the whole process of who got vaccinated, when they got vaccinated, when they got hospitalized, who got hospitalized, etc., etc. So one could track for that whole period of the epidemic what went on in this population. So what are the considerations? So I did a full review. As I said, people debate this thing from like very narrow angles. So somebody will say it's not fair. Somebody would say it's not practical. Somebody would say you can't, for whatever reason, it's not ethical, blah, blah. So there's like a whole lot of different things that people debate around, but there hasn't been, as far as I could tell from the review of the literature, where somebody has put together kind of almost a model for assessing the whole thing. And out of this review, I mean, essentially the guts of, if one takes all these debates, there's kind of three things that are critical in terms of assessing this case, right? The first one, so this would apply to any application of any personal responsibility issue, right? So the first question would be, you would ask, is would applying personal responsibility make a difference, right? If the thing doesn't make, so I'm going to penalize you for your bad behavior, but if it doesn't make a difference, then it's pointless penalizing in the first case, right? So the first question then is, does it make, so will application of personal responsibility force a change in behavior? Would that force change in behavior result in different health outcomes? Would it result in different utilization? Would it result in different expenditures? And if you can't prove that, I mean, then basically it's pointless even going down the road, right? So that's kind of the first condition. The second one is ethical, right? So we all live in societies, we all contribute to society, and we get back from society. Not everybody contributes and claims from society equally. And that's where distributive justice comes in. So distributive justice says, in a society where we're all living, some people will contribute more, somebody will claim more. But how does one find a reasonable balance between what you contribute and what you claim from society? And that's the whole issue of distributive justice. Now, there's different theories. I mean, and that's where the problem comes, that not everybody has the same view on what constitutes ethical kind of this thing. I mean, the views on distributive justice are quite different, and there's whole schools of thought that come around distributive justice. Right? So the first one, I'm going to just give you the high-level one, is the libertarian one. So the libertarians basically value individual freedom. So essentially, they believe that humans have, what's the word? Agency, right? Agency. So you are, as an individual, you're a human being, you're intelligent, you have agency. So you must think for yourself, and you must make your decision, and you must then be responsible for whatever choices you make. So and that's the Trumpian view, the libertarian view. So I mean, they would say, listen, don't tell me to wear a mask. Don't restrict my movement of access. Allow me to make that choice. And I'll take the part that they don't talk about is the consequences of the choices that they make. I mean, they're quite silent. They'll talk a lot about the freedom and the individual freedom, and they don't want the state to restrict them in any way. The one I'm quite keen is to kind of pick up on the consequence side of it, because they don't talk about the consequence side. But essentially, that's the libertarian view: is, listen, the state shouldn't interfere. I should be allowed to do whatever I want to do. Right? The next is the classic egalitarian, and that's essentially most liberal, the West and neoliberal kind of democracies, where equality is the fundamental value that we want. And so everybody should have access to care. And the thing that the egalitarians kind of don't consider too much, I mean, it's considered, but essentially they said, listen, it's too difficult to deal with, is the issue of personal choice. So, I mean, essentially, if you look at most models, Western democracies, the NHS, and so on, they would give you access. Everybody has, they strive to give equal access to everybody without taking into consideration the personal behavior components. I mean, if you go to the NHS, everybody should have access to care based on their needs, right? So, I mean, there's no, the personal behavior portion of it is kind of behind the scenes. So that's a classic egalitarian. Then you've got the communitarian model, which is kind of the public health model, the Chinese model, which says, listen, the society, we live in societies. In society, the needs of the community and the broader society are more important than the needs of the individual. So you must, essentially sacrifice your individual freedoms and so on in order for the greater good of the society you live in. And public health is basically built on that model. Is to say, listen, that your individual decisions and things have broader consequences. So, if you don't vaccinate for measles, eventually measles will run riot, and that has a broader consequence. And therefore, for the broader public good, the societal good, we have to restrict some freedoms. And that's essentially what happened during COVID as well, right? That we tried to mandate limitations on movements, we asked people to wear masks, etc., because it was in the broader greater good. The utilitarians essentially say what generates the greatest good for society is what is good. So if it means restricting individuals in certain ways, but if the ultimate outcome results in the greatest good for society, then that's justified. Right? Then the last one, and it's the one that I'm going to use in terms of, or I'm using two of it, is luck egalitarianism. So luck egalitarianism says basically we'll compensate people for ill health from broader circumstances. So if you end up sick and so on, we'll treat you equally. All people who get sick because of the circumstances that they're in, we will treat them equally. But if you deliberately make a choice and we can prove that you've deliberately made a bad choice, then you should be held liable in some way. So it's a personal responsibility can apply if we can kind of almost demonstrate that you made a choice, not an involuntary choice. You made a choice. So you don't get sick because you live in a poor area and the conditioning is bad and the food is bad and you got sick. We can't hold you responsible for that. But if you have the means and everything else, then yeah. So like egalitarianism is a slight kind of twist on egalitarianism. And then the third component is practicality. So in this COVID vaccine thing, the thing is quite clear in a way. The outcomes, demonstrate to you that the intervention and everything else is quite a clear outcome. But like smoking and others, and then that's a debate that's going on now in Britain as well. So if you imposing this age restriction progressively, right? So people who are above certain age can continue smoking. People below that age now will not be able to access. See, there's a 1 year difference from the application point. They have two totally different. So one can buy cigarettes because they're born a year old, and the other person's a year younger and can't buy cigarettes for the rest of the year. And one looks at like the more kind of broad issues of smoking, alcohol, whatever the case may be. Those things are quite difficult to apply. So the practicalities of the application is the important one. If you can't apply it practically, then don't consider it, right? So those are the three very broad criteria that I kind of put together from the literature review in terms of, I'm saying, if you want to apply personal responsibility, you've got to go through those three criteria and then make a call, right? So for this research, we then ended up taking those three criteria, but we're applying it now to COVID vaccination in an insured population. Right? So the first one was impact. And the question is, will COVID vaccination reduce COVID-19 related mobility, utilization, and expenditure? And that's what I'm presenting to you today. The next parts of this research will look at the fairness. So the one would look at luck egalitarianism. And in that component of this piece, we'll then say, did the people who were insured in South Africa, did they make the choice not to vaccinate as a result of circumstance, or was it a choice? And can one kind of prove either way as to whether they made a choice? So it's a difficult one. One would have to look at what messaging was sent, you look at the socioeconomic circumstances of the people, where they lived, etc. But ultimately, you got to build a case to say, did those that didn't vaccinate, was it a choice thing or was it a circumstance thing? And that would be kind of the second part. And then linked to like egalitarianism is equality, right? So the issue then is if you're vaccinated and you didn't vaccinate, what is the equality implications of the two? And it links back to the first one. So if you were vaccinated and your hospitalization was much lower. So remember in an insured environment, everybody contributes. If those who vaccinate, the expenditures and everything else is much lower than those who didn't vaccinate, then there's an equality issue in terms of claims from the system, because those who vaccinated claim a lot less, and those who didn't vaccinate claimed a lot more. And then the question is, what is the cross subsidy that went on? Right? And is that fair? In an insured environment, we all contribute the same. Because of differences in behavior, some claim a lot more. Is that fair now for those that are now having to cross subsidize? So that will be the second part of this thing. The third one is a utilitarian one, right? To say, well, was it cost effective to vaccinate or not? And ultimately, that's the question. Could we just allow people to go get their hospitalization? Or if we paid for the vaccine, did we save money? And ultimately, if you save money in an insured environment, it means reduced contributions, or you can use that money to provide other services. So there's a greater good component to it, right? And then the last one would be the practical. So how would one penalize if all other conditions were satisfied? In an insured environment, how would you penalize those that didn't vaccinate, right? Would you say they don't get any hospital benefits? Would you make them pay some kind of co-payment? Or would you have a higher contribution premium? And that's kind of assessment we're going to do down the line. You with me so far, right? You got the broader picture. So basically the data that the study is a cross-sectional study. I mean, essentially what I got was the demographic is your member information. And then the claims records of all these two medical schemes, about 50,000 individuals. They're in the data warehouses of NMG Consultants and Actuaries, the company that I work for. And we pull the data from 1st of March 2020 to the 31st of December 2022. So the 1st of March was the onset of the epidemic in South Africa. About December 22, I mean, we'd seen almost the tail end of the last wave, the fourth wave in this country. So we basically picked up the claims over the entire peak part of the pandemic. And what I got is all the demographic information. So we don't have everything, but I mean, we've got age, gender, where they live, province, etc., etc. And then we've got all the claims. And in terms of the claims, we've got all the information on the hospitalization that people went for COVID-related hospitalization, the vaccinations that they got and didn't get, right? So I mean, remember this data is not designed for study purposes. I mean, it's there to pay claims. Right? So it requires a lot of massaging. So I'm not going to go through the kind of the details of it, but essentially we took all the claims data and we created the various data sets in order to carry out the analysis. And we set up specific data sets to look at the different pieces that we were interested in kind of analyzing. The outcome variables we were looking at then was so the risk of hospitalization. So how likely were you to get hospitalized? Secondly, we looked at how many days you spent in hospital for COVID. This is COVID-related stuff. And then thirdly, we looked at expenditures. Again, COVID-related expenditures in hospital, right? We didn't look at out of hospital and day to day and so on. So the explanatory variables then in the analysis, and that's the key one was obviously COVID vaccination. And we use the WHO in kind of pretty standard definitions in terms of coming up with, we define people as being not vaccinated, part vaccinated, and fully vaccinated. And this thing changed over time. So remember, you're going from one point to the other. At different times, people got vaccinated. So they might have, depending on which vaccine they took, they might have become fully vaccinated immediately, or they may have, if they took the other vaccine and it became partly vaccinated. So I mean, essentially what we created was a timeline for every individual as to when what their vaccination status was at different points in time over the time period. Well, as I said, and that is like the main one, but obviously when you do this kind of analysis, you also want to, the big other factors are age. You'll see it from the results. So you want to compare, if you want to compare the vaccinated versus the non-vaccinated, you want to then adjust for all the other things that might have affected utilization and so on. And the two biggest ones are obviously age and chronic. That's all the literature's done it, and we've got that as covariance. We included province because we had the data, but you'll see it didn't make that much of a difference, but it's there. And obviously gender, and there's a difference between gender. So essentially the impact of COVID adjusts for all other things being equal in terms of gender, age, chronic, province. What was the impact of COVID vaccination, right? The analytic challenges, as I said, was that people entered medical scheme. This is live medical scheme, so people come in at different times, they exit the scheme at different times. So the exposure over the period varies. They got vaccinated at different points in time, and they took different vaccines at different points in time. They got hospitalized. Some got hospitalized, or few got hospitalized, many didn't get hospitalized. And then some of them got re-hospitalized. So there were multiple admissions. And then some of them died or exited for whatever reason. So there's all of this going on. And to create this data set, one required quite a lot of work to almost create time series of everything that goes on. Yeah. And then there was obviously, Francesca's here and she can talk about it, but the data is not normal at all. So it's very asymmetric because remember, most people didn't get hospitalized. A lot of people didn't get COVID and so on. And we took the entire population. So most COVID studies have taken people who are either hospitalized or people who had COVID and then got hospitalized and looked at it. So it's a negative case matching study, whereas we took the entire population, so you can understand what's going on. We take this whole population and what kind of happens to this population over that epidemic. And that was kind of the key of nice thing of having this data set that we had. Yeah? So the univariate statistics, we had hospital frequencies and hospitalization rates for risk of hospitalization. For utilization, we had the total days in hospital, days per hospital event, and hospital days per 1,000 lives. And then for expenditure, we had total expenditures, expenditure per hospital event, and then expenditure per individual. And then on the multivariate analysis, again, it was quite complicated, and Francesca did a lot of this work. So for the risk of hospitalization, we used survival analysis, and we used the Cox proportional hazard model to estimate. So essentially, remember, this is like a time series. So you're looking at time when they entered, when did they vaccinate, how long did it take to get vaccinated or change vaccination status, how long did it take to get to hospital event or not. So basically and that's why we kind of use the survival analysis. As I said, the time varying vaccination status was incorporated through repeated measures per individual relating to the periods with different vaccination status. And then repeated observations by individuals with multiple vaccination periods and hospital events. We took that into consideration by incorporating data clustering by option for the individual. And then we're reporting on unadjusted hazard ratios and adjusted hazard ratios with 95% confidence intervals. So that was what we did for the risk. That's essentially saying how likely were you to get hospitalized. And then on the utilization and expenditure, we use the zero inflated negative binomial model. It's called a ZIN-B model, which is because of the highly skewed distribution of not only the zeros, but also the skewed distribution of the non-zero. Because remember, some people got hospitalized, but the variation in once people got hospitalized is huge. Some people end up being released within a day. Some people spent 100 days or 200 days. So that was a kind of a very skewed distribution as well, and that had to be taken into account. There were repeated observations again for individuals, so individuals with multiple hospitalization. So again, there's a collinearity issue there. So we use data clustering option by subject. And then the outputs, we had the count component and the zero inflated component. The results are very consistent across both sets of results. So what I've presented is only We got, this is not my machine. Okay, so let me try and get this thing through quick. So, okay, so the results are like really compressed. I mean, there's like multiple millions of tables, and I'm not going to go through all the tables, but I've compressed the results as far as possible. So the blue bars here are basically your unadjusted hospital days per 1,000 lives. Right? And if you take over vaccination status,
It's interesting. It's the slides are still. Sorry, colleagues, I'm speaking. It's Sue here. So the battery failed in the venue on the laptop, but I see that you can still see the slides. And so I think Hitesh can continue in the meantime while I get things to project in the room. I hope you can hear me.
We can hear you,
Thanks.
but maybe Gitesh could just practice moving a slide on, because I suspect it's just the slide that was up when the battery failed.
Does it work?
Well, there's one slide that it hasn't moved.
Hasn't it? Okay, it's moving on my side.
No,
Is it
it's
not
still
moving on
with-
your side?
you must share it.
Okay, all right. I'll share again. Can
Which
you
one, please?
plug in
Which one?
all of them? I don't know. Just see what
Which
you
one is
do. So
Hitesh, could you please just hold this? You like the laptop?
which one is it? This one.
This one isn't going.
Yeah, now we have to stop sharing. Take control. I want to take control.
One is in. I don't know if this is, I don't know. Why did you have three of these? You have three plugs.
For the camera.
Okay, so is this helping in any way?
Turn the camera on here as well.
Mm,
Yeah,
We've
there
got
we
the
go.
first slide up.
Okay,
That's
cool.
it. Is it all?
Thank you, guys. We are nearly there. Just get you back to where you were.
Okay.
These guys can't see more.
So the only thing is to get this to work. Where was the other one?
Oh, the other one I won't go in.
Okay, we're back at the results slide, first results slide.
Okay, thanks. Yeah, we just don't have it visible in the room yet.
Okay.
And then the third one is probably.
Right. I think we're getting there.
Sure.
Oh,
Here we go.
oh,
Okay, we're back.
you put the
No,
thing off
yeah,
the-
sure.
Oh, thanks. Sir. Okay, so as I said, the main issue here was vaccination. So I mean, the other results are there, but I'll show you the vaccination ones. So the blue bars are essentially your days, the unadjusted days for the hospital rate events per 1,000 lives per year. You can see, so that's a non-vaccinated, partially vaccinated, fully vaccinated, and you can see how quickly the thing drops, right? And then if one does so one does, after the adjustments for age, gender, blah, 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 the vaccination rate or the hospitalization rate for the partially vaccinated was 94% lower than the non-vaccinated. And for the fully vaccinated, it was 93.4%. So there's almost a 95% reduction in the hospitalization rate for those who are vaccinated, right? And it's a huge impact in terms of hospitalization, the risk of hospitalization. And then the results for the rest were pretty much consistent with all other things. So generally, males were more likely to be hospitalized, all other things being equal. So huge upward tick in terms of hospitalization with age. You can see is this. So the adjusted ratios are not even here because it went off the chart. So I didn't put those numbers there, but you can see it's like almost 17 times higher for the plus 65s compared to the under 18s. Chronic, again, the same kind of pattern you got. So essentially, if you had a chronic condition, you are much more likely to get hospitalized. And then over the patterns over the provinces weren't that different. Or, I mean, there was, but nothing like kind of really stood out, right? If one looks at utilization in terms of days, the same pattern. Now you would expect, right? So if you're less likely to get hospitalized, your days are going to be less. Right? So I mean, it's kind of looking at the same thing in a different way, but the issue is, sorry, Leslie, what's up? Hi, Leslie. You got a hand up?
No, I pressed the hand by mistake. Don't worry.
More disruptions, yeah.
Yeah, more disruption.
Okay, so the issue, I mean, partly is that and this kind of reflects that. So you would expect differences in that those who got more hospitalized will have more days, but the issue was also the intensity of the treatment when you got to hospital, right? So generally, if the vaccinated and the non-vaccinated ended up in hospital, the vaccinated generally ended up with less days, less expenditure, because they were less likely to get into ICU and everything else, right? But bottom line again is that the part vaccinated had almost 17% lower days in hospital, and the fully vaccinated had 13% lower days in hospital. And then if one looks, and then the other patterns again, I mean, the same, so I'm not going to belabor the point, right? And then if one goes at expenditure, same story. And so the expenditure, hospital expenditure for the partially vaccinated was 28% lower than the non-vaccinated, and almost 40%, 47% lower for the fully vaccinated. So effectively, we spent a lot less on people who vaccinated, right, in hospital. So in summary, then, if one were to take the impact of vaccination across the three measures we looked at, right? So you're looking at huge impact in terms of risk of hospitalization. You've got a much lower reduction. You use less days in hospital, and you spend a lot less in hospital, right? So ultimately, I mean, then one argues that the research confirms that COVID-19 vaccination made a significant impact on the risk of hospitalization, on hospital utilization, and hospital expenditure. And the findings here are essentially in alignment with everybody, what people have found elsewhere in the world. So they're not necessarily anything unique and new. I mean, as I said, it's part of a bigger picture story here, but essentially the study is consistent with the findings elsewhere. What is different in this study is that it's not just the real world cohort, but we took the entire population. As I said, lots of other studies, even real world studies, have looked at people who already had COVID and looked at hospitalization, or they looked at people who are hospitalized and said, do they have vaccination or not? Whereas we followed this whole population right from the beginning, everybody who was in the system, right? There's quite a lot, so there's a lot of work that's been done in China, the West, the North, and everywhere else. The amount of work that's been done in Sub-Saharan Africa, South Africa is quite limited. There has been work done, but not a lot. So this kind of adds to that evidence base. There's been very little done on insured populations. So other than in the States where they looked at Medicare, Medicaid patients, I mean, there hasn't been a lot
done in insured populations, and the study kind of adds a unique perspective of that. And then the last one is the utilization and especially the expenditure information. So a lot of studies have looked at utilization, the risk of hospitalization, but very few, I mean, I've found hardly any studies that have looked at the expenditure impact of this. And you can understand in a public sector environment, a lot of those studies were done in kind of public sector environments. You don't have the expenditure data, whereas in this situation, we had the actual claims that people did. So in that sense, there's like really nice information that came out of this study. Yeah, these are all negative figures, eh? Going down. Reduced, yeah. Yeah. Utilization was, yeah, but I mean, it wasn't statistically significant, you know, so it could have been out. As I said, you had these huge variances, right, in the mix.
Just let's think what is the sample size of the population?
550,000. 550,000 individuals. Yeah. So then coming back to kind of the broader picture, remember I said there's 3 things one needs to do, or we're going to planning to do 4 things. So I would argue we've ticked off the first one, right? And we'll then now go through the other pieces of this whole thing and then come up with an overall case as to whether it would have been justified in this thing. I want to stress again, I know Leslie's here, so that the generalizability of this is limited. I mean, we're doing this on an insured population. It's very different from the general population. There are lessons I think we can learn in terms of like going through the thinking around it, but the results that we come up with here are specific to this population. Yeah. And that, I think, covers it. I'm happy to take any questions. So I want to acknowledge again Sue and Francesca for all their help. HSRU, MRC for tomorrow for the funding on this work. And then a lot of my colleagues who've been my advisors and helpers along the way. So I just want to acknowledge all of them in terms of their contributions to this.
Thank you, Gitesh. This was very, very interesting, and I'm sure there are lots of questions from both online and in the lecture room. So where do we start? So maybe here. Any questions, comments from the audience? Anna?
Besides Singapore, anyone else that it has sort of been done?
So they tried it somewhere in Canada, I'm not sure, and in Germany, and so Germany's got different states, and each state does its own thing. And I know in Germany, some states they considered it. I don't know if they actually implemented it, but they definitely considered it.
Expenditure, I mean, that's one part of it, but I think that we can think of this as a sort of set of experiences around, you know, it also has applicable to the question of whether it was okay to do vaccine mandates, and in lots of different countries that did that, different workplaces did vaccine mandates. In certain countries, if you weren't vaccinated, you weren't allowed to go to a restaurant and so on and so forth. So there's a lot, and I think it's important to reflect on this pandemic in terms of what we did right, what we did wrong, and the lessons that we need to learn from it, even if we're not alive for the next pandemic, so that the next set of public health people have a set of literature that they can look at. Because I remember at the start of this pandemic, they all tried to find literature from the Spanish flu, and there was next to nothing that we could actually read about. There was very little literature available. So we're trying to sort of, at least we need to look back on this experience in order to have stuff for the next generations. I think that that's also part of it, even if we don't think that this is generalizable to smoking or to risky skydiving, to, you know, what else.
Eating nothing.
I think that's, yeah.
But at the very minimum, I think, as I said, the idea that there's a framework, right? So you can apply this framework to think through other applications. I mean, and that's what I was quite interested in. I mean, like it's now reduced, I mean, because the arguments are all over the place. And then in this framework that I've now put on, yeah, actually simplifies it. I mean, I think it gives you a nice way of assessing this, impact, ethics, practicality.
Question from Marianne. Marianne?
Hi, thanks very much. Thanks for a great presentation and really interesting analysis. I'm going to focus on the vaccine effectiveness analysis just because that's work that we've also been very involved in, more in the public sector. And Reshma, who actually conducted most of our public sector analyses, is on the call as well. So she may want to comment. And I see there are also questions in the chat related to this. So I think it's amazing to view such a huge data set, and the results are certainly, quite compelling. I was interested in a couple of things. The one is the strikingly high effectiveness of partial vaccination, which I think is probably higher than's been reported in the literature. And I wondered about what your definition of partial vaccination was. I'm sorry if I missed it. The other is there was a question about taking the different waves into account, but also whether you accounted for duration since vaccination and boosting in any way, because we've certainly shown, and I think Reshma will post a link to our preprint in the chat, and I think, and others have also shown a massive reduction in effectiveness with longer duration since receipt of vaccine. And then the other thing I was interested in, whether you did any adjustment for differences in healthcare utilization, and particularly in testing, although perhaps that's less important since your outcome was hospitalization. But if there were differences in access to COVID testing and generally in healthcare utilization between your groups, that could have impacted the effectiveness estimates. So yeah, I don't know if Francesca perhaps is available and would be interested to comment. And it would be really nice to chat further and collaborate on the best methods for doing these kind of analyses in these huge population cohorts, both for this analysis, but also as we look to the future. Thanks very much.
Thanks, Marianne. I don't know if Francesca, do you want to come in and comment?
Well, I can comment in general. So yeah, it was surprising that, well, to me, it might not be surprising to Gitesh, the partial vaccination result to the full vaccination result. And the whole time while we're doing all of this, I was very worried about biases that we may be forgetting about. And one of the biases, and I haven't had my hand around it, so I'm pleased to hear that you've done it, and I think Reshma and I should meet over a cup of coffee, was the time elapsed, because obviously we cut things off, and have we maybe given certain exposures just not enough time to be there or not, if that makes any sense. So that was the one thing. When we broke it up into waves, we started seeing funny results, which we need to return to, but haven't done yet. Some waves totally supported what we were doing, whereas others, maybe at the beginning and the end of the epidemic, where maybe you didn't have the different exposure categories anymore, obviously gave funny kind of results. Yeah, so the big thing was, are there biases we're forgetting about? The whole time varying nature of it, which I think we've captured through the methods. Of course, Gitesh is choosing not to show half of the zero inflated model results, which is the probability of a zero. He's just showing the other part of it, but it is there and it confirmed and supported what you're seeing. Yeah, I don't know whether that answers any of your questions or comment on your things, but I would love to see what you've done and to chat to you and Reshma.
And just to say on the definitions of vaccinated, partial vaccinated, I mean, we use the discovery one, but there was, I mean, it's been used quite standard. So I can't remember which vaccine was what, but the one vaccine kind of essentially said if you took this, then within 14 days you were fully vaccinated, and the other one required you to take 2 vaccines. So basically we recorded after the first one, so many days you were partially vaccinated, and after the second one you became fully vaccinated. And we then, I mean, in the data set it was recorded depending on which vaccine people took, how, at which point they became kind of partially vaccinated or fully vaccinated. So it's kind of pretty standard, the definition we use. I mean, I just can't remember the details here.
Yeah, thanks so much. That's great, and I think this has been a great opportunity, and we'll definitely get in touch with you, Francesca.
Hi, Rashma. Do you have a question still?
I do, thanks. And it would be great to chat, Francesca and the whole team. We've been so immersed in this in the last couple of years without getting to really talk to other people who are looking at these topics. So sorry if I missed this. I was driving through part of the presentation, but I was trying to understand how does one get the very big difference in hospitalization rates and then not a big difference in utilization, which, if I understood correctly, was how long people are in hospital. And again, sorry if I dismissed this while I was driving. And the second question is, the vaccine data, is that based on people claiming for their vaccines, or is that actually data from the EVDS? Thanks.
So the second question, yeah, it's from the claims data. So there is an issue around the claims data. I mean, so I know the Department of Health went through a whole process to try and make sure all the claims went through, but there may be gaps in that data to the extent that the claims didn't come through to the medical scheme. On the issue of the utilization, I mean, there was huge. I mean, Francesca picked it up as well, that this thing could get distorted quite quickly and biased by, as Francesca said, length of stay. So there were some people that were there in hospital for over a year, of very long periods of time compared to others who had short stays. And that whole thing could have been distorted just by 1 or 2 cases that were there for a very long period. Yeah.
Okay. Thank you.
So that's the entire population, on average across the entire population. That's not targeting in on those that were hospitalized.
Yeah, no, so we ratioed it over there.
So there's a question from Leslie. How is it possible that both men and women have hazard ratios greater than 1?
No, the hazard ratio for the women was 1, and then the hazard ratio for the men was higher. I think you got it wrong, Leslie. So the reference group was females, and the hazard ratio was 1.
Okay.
That's 1, eh?
Oh, yeah.
I mean, if you look at where the yellow line is, I mean, basically that's the 1, right? Adjusted. The blue bars are based the actual utilization per 1,000 lives.
Okay.
They're on different axes. Eh?
Okay.
I just tried to compress this as much as possible for the presentation.
All right. Yeah.
The age distribution of nation status.
The one could have. Yes, I mean, it is interesting that the higher risk were more likely to be vaccinated. Right? I mean, that is like, you can see it through the whole thing. And so if you look at the unadjusted things, you can see like how this thing plays out. When you adjust it, the thing kind of reverses. So basically the chronics in the higher age groups were much more likely to be vaccinated. I mean, there are people, it's interesting, I mean, it comes to this behavior, right? That those that were high risk kind of took the precaution and said, listen, we're going to get vaccinated. Whereas the lower age groups, the non-chronics, the healthier people kind of took their chances and decided not to vaccinate.
And then a question from Vanessa. Is the analysis overall the 3 outbreaks, or did you see different patterns per perhaps with built-up immunity?
We didn't. I mean, and it's Francesca kind of, so we looked at it, but there's just so much to this thing. So for the purposes of, my exercise or what I'm trying to do is say, over this whole epidemic, that period, what happened? And there's a lot of moving parts in the whole thing, so we had, we've got the data segmented by different waves and everything else. But the purpose of what we were trying to do is a bit different from actually doing the thing of what happened against vaccine A or what happened with virus A, etc. The issue was in this population over this period, would it have been, what was the impact of vaccination? So it's a question kind of slightly a bit different from what Marianne and everybody else has been doing, because they've been looking at specific vaccines, specific viruses, etc. The purpose here was kind of a more policy one at a global level.
Then there's another question, quite a tricky one from Poonam. Most private hospitals use.
Poonam, you weren't supposed to ask questions, eh?
Well, here we go. So how did you actually relate these to COVID-19 admissions out of other admissions?
Reasons?
Just in the middle where you're looking straight. Most private hospitals use these codes, but how do you differentiate?
No, so basically the NMG people did this because we were reporting on COVID. This thing, and I can go back to them. But as I understand it, they took the specific ICD codes that were there for at the time of admission. So if one goes back here, there was U07.1 or U07.2 that were used as the ICD. So on admission, if that was the ICD code for admission, then it was considered to be a COVID admission.
Okay, so they were COVID specific.
Yeah,
Okay.
and so I think there's a bit of a problem with that though. So working in the private sector as well with the data we have, we saw that most of the hospitals actually use those codes on admission, even before the patient was actually tested. And so some of the admissions that would end up in there are also cases that had incidental COVID. So the example I gave is someone who comes in because of some trauma-related thing and then incidentally tests positive for COVID. So on our side, we've had to do a lot of cleaning of the admissions data to separate what's truly COVID related and what's not.
We can chat about it, Poonam. I'll have to check, because this is the internal algorithms at NMG that extracted the data. So they basically, I didn't get directly involved in the extraction.
Okay.
Question from Gavin? Yeah. Gavin? Go ahead with your question.
Yeah, sure. Thanks, Gitesh, for a great presentation. So it was striking the difference in adjusted hazard ratio for age. So that was extremely high, which makes me wonder about treatment intervention bias, and particularly because this is a private sector patient. So if they have beds, they're probably motivated to fill them. And the question is, to what extent would patients have been admitted because they have COVID and they're elderly, or have COVID and they have chronic illness? And then the same for vaccination, so that there's a bias towards admitting them if they're unvaccinated, and just using that to try and interpret these results. And then I'm also thinking that obviously that bias falls away with deaths, to a large extent would fall away with deaths. And are you thinking of extending it to deaths as well?
So I agree. There might be a bias in terms of, there was sufficient capacity in the private sector, as I understand it at the time. But so I don't know. They weren't going out and scooping people. People were rocking up, and then whoever got admitted. So I'm not sure if there's a bias in terms of who got admitted. It might be who presented at the hospital, might be a different issue. Yeah. on the, what is the second question?
Deaths.
Deaths. Oh yeah. So we have information on deaths, but the data again, like when will say, you know, you don't. So you again, this is remember medical schemes data. So you don't always get the reason why people leave. I mean, the only time you know is people leave, right? So then you'd go. So you don't get information directly from what's it, the forensics or. I mean, essentially, medical schemes record when people leave. They'll try and find out why they leave, and then they might get listen, this person is leaving because of death. You know, so it's not always very clear, the death data, as to what the reason for exit from the scheme is. And it requires a whole lot of more cleaning. And as I said, you know, for the purposes of what I wanted to do, there's already too much here. So I mean, I've done what I think I need to do for this part of the thing. There's a lot more other steps in this whole exercise. But I'm happy to talk with others who are interested in taking it further.
Just before we close, there's an interesting comment from Leslie. Is it possible that, is it possible that the possible vaccinated group got their second vaccination outside the private sector, in which case they are misclassified, at least some of them, as partially vaccinated, which may explain the very high protection since fully vaccinated were misclassified as partially vaccinated?
It's possible, but I mean, everybody got vaccinated through the system. I mean, it was a common system for everybody, public, private, and that is what is so incredible about the COVID time, that everybody got through. And was the only missing piece, and I mean that's been raised, is that to the extent that they didn't claim, the government didn't claim from the medical scheme, that information wouldn't be there.
And the record keeping was perfect, so we knew
Yeah.
exactly who,
Yeah.
regardless of the sector.
Yeah.
All went through the government.
Yeah.
And then there's the question to what extent government send through the claims to medical schemes or not.
Yes, in which case we wouldn't have those numbers.
And I would think that that's something to investigate.
Yeah.
Yeah.
Yeah. Just something definitely to check forward. But thanks very much. Thanks, Gitesh, for a really interesting presentation, and good luck with your next criterion, which will be even more challenging. So we will, I think I will invite you again as a guest. Is that all right? When you have some more to share with us, because obviously it's a very interesting and still relevant topic. And as Sue said, we get a lot of data and for future generations. So thanks everybody online. And
thanks everybody for sitting in.
And a big thank you, Gitesh, again. Really, and good luck with your PhD.
Thank you.
Bye everyone.
Bye-bye.
And thanks.
Thank you.